This video is going to be about preload and CVP. It's the first video in the hemodynamics series, which looks at preload, contractility, and afterload. So these are really important concepts in blood pressure and hemodynamic stability. I've noticed when working on the floor that if someone's blood pressure is low, the most common response is to give fluids, give a fluid bolus. Whereas when I worked in the ICU, the most common response to a low blood pressure was to increase a pressor, like Levophed or norepinephrine. And people sort of get in this one track that that's how you fix a blood pressure, when in reality it's this complex picture including preload, afterload, and contractility. And in reality, preload, afterload, and contractility all work together and are really interconnected to create a good blood pressure. So it's knowing how these forces connect and how they work together that tells you what to do to fix someone's blood pressure. So this video is going to be about preload. We're going to look at CVP, how to read a CVP, and what it tells you. So when I think preload, I think volume. Volume or fluid status. If you take only one thing away from this video, I want it to be that preload has to do with volume. It has to do with preload in your ventricle. So I'm sure you've all heard of the Frank-Starling law. You've got this curve here, Frank-Starling curve, and basically it's saying that your ventricle is like a rubber band and you need the optimum amount of stretch to get the optimum amount of contraction. So here's the curve, and you want to be somewhere right here on the curve. But basically you've got these contractile fibers in your heart that look something like this. Actin and myosin. And there's a little bit of overlap here where they can connect and you can have contraction. So the idea is if you have barely any overlapping, you don't have very much contraction. And at the same time, if you have too much overlapping, it's almost all overlapping, you really can't move much because they're only moving from here to here. So ideally you have the perfect amount of overlap that you can get enough grasp and also have enough room to move and contract. So preload, the amount of volume in your ventricle before contraction, is what gives you a really good contraction and better cardiac output, which leads to better blood pressure. So there's two ways to look at this. I would say the main one is making sure you have enough volume in your system, because you've got, let's say this is your heart, and you've got your superior and inferior vena cava coming back to your right atrium, and then from your left ventricle you've got your aorta coming out. It's going to go to your tissues and come back. So you've got this loop here. And you have to make sure that you have enough preload here to fill your ventricles so you can have a really good, efficient contraction, good ejection, and you can have a good blood pressure. So if your preload is too low, and that's why your blood pressure isn't good, the easiest thing to do is to increase your preload, so increase the volume that's sitting in that ventricle and stretching it. So there's three ways to increase volume. The first way is to give a crystalloid. And I would say that's what we do most often. That could be like normal saline, LR, something to increase volume. In addition, we could give a colloid. So that's a solution like normal saline, but it has albumin added to it, or protein added to it, or some kind of substance that pulls fluid towards it. So albumin can come in 5% or 25%. And it's just saline with albumin protein inside of it. And the albumin won't leave the vessel, meaning that it draws fluid towards it. So the takeaway from that is you can give less volume total into their IV, but you can increase their intravascular volume more per what you're adding compared to a crystalloid solution. And the third thing you can do is give blood or blood products. So if someone is hypovolemic because they've been hemorrhaging, blood should be included in the fluids that you're giving them. You'll probably give them some crystalloid as well, and then give them some blood to give them that volume back as well as the oxygen carrying capacity. I do want to point out a different scenario though that can cause decreased preload without having a problem with your volume status, and that is increased heart rate. So like AFib, your heart is pumping so fast that it doesn't have time to fill. And you know that in a normal contraction cycle, 1/3 of the cycle is systole and 2/3 is diastole. However, when you have that heart rate speed up so fast, systole doesn't change much. So systole still takes about the same amount of time. It can increase maybe a little bit, but the amount of time it takes for that heart to contract and get to full systole is about the same amount of time. However, the time that it's allowed to relax is then just cut. So we have mostly contraction with not very much relaxation. We lose our filling time, and so our end diastolic volume, or our preload, is low, even though we might have a lot of fluid back here waiting to get pumped out. It just can't get into the heart between beats to get pumped out. So in that case, it would be a bad idea to give more fluid because we might already have a fluid backup and we might make the problem worse. In that case, we should give a drug for the AFib to decrease heart rate, maybe a calcium channel blocker or a beta blocker, so that we can increase our filling time to increase our preload. So even when you've determined that the problem with blood pressure is a preload problem, and you know that preload has to do with volume, remember it has to do with filling volume, not necessarily total volume, so it's important to differentiate where the specific problem is. So now let's talk a little bit about how to determine preload, how to read a CVP. So when you're looking at preload, you need to look at your CVP. And if you've watched any of my other videos, you know that my videos would not be complete without a mnemonic or two. So here's one. CVP, it stands for central venous pressure. But if you forget why you might need to look at your central venous pressure or your CVP, it would be to consider a volume problem. So you look at your CVP, especially if someone is hypovolemic or they're septic and you're worried that they might not have enough preload, they might not have enough volume. You would want to consider a volume problem. So in this video, I'm going to talk about the concepts of the CVP in general, where you measure the CVP as far as during and expiration, but I'm not going to go into the actual letters naming the parts of the CVP waveform. I'll save that for a different video. So if someone has a catheter that can measure CVP, it's going to sit at the junction of their superior vena cava and their right atrium, or maybe a little bit above that in just the superior vena cava. So there's a heart. Here is your superior vena cava going into your right atrium, and the catheter is going to sit right about here. And so generally people put in like a central line, like a IJ central line, internal jugular central line, or subclavian central line. I've seen it usually when they come back from a heart surgery, they've got this line already in place. And you can connect to the most distal catheter. So usually it comes out and there's like 3 ports you can choose from, and one might end here, and one might end here, and then one goes all the way to the end. And you would connect your CVP transducer up to the one that goes to the very end, this one here, because you want it to stick at the very end of the catheter and sort of see what's just beyond the catheter. So you transduce this and you hook the tubing up to your monitor, and your monitor will read something like this. And like I said, in a different video, we'll go into the letters, but pretty much when you look up at the screen, it looks like this. And it's got some oscillations with respiration, which we'll talk about. And then your monitor will pop up a number, and normal is somewhere between 2 to 6 millimeters of mercury. And then you can also calculate it with calipers sort of manually on the computer and verify the accuracy of your monitor. But for now, we'll talk about what the monitor gives you. So it gives you a number. Normal is 2 to 6 millimeters of mercury, although current research is saying that the CVP number itself is not that accurate, and we shouldn't be treating specifically on one number. So if you hook this up to a patient for the first time and it reads 16, it doesn't mean you necessarily need to like diurese them and get some fluid off. It could just be them, it could be their physiology, it could be how the monitor reads. So the most important thing is a trend. But traditionally, 2 to 6 millimeters of mercury is considered normal. If someone is vented, it might be a little bit higher, maybe 6 to 8 to 12 millimeters of mercury. And we'll talk about why it might be higher in a vented patient. So the relationship between the lungs and the CVP is very important. It's a relationship that seems to come up again and again and be really important for other concepts like stroke volume variation and how putting PEEP on your ventilator can affect your cardiac output. So I'm going to draw some lungs here. And obviously this is not to scale, but I always sort of picture my lungs here next to my vena cava to help me remember the concepts. Of course, in reality, your vena cava is in front of your lungs, but regardless, when your lungs move, they squish your vena cava, and that's the point that I'm trying to get across here. So let's say you are spontaneously breathing. So when you take a big deep breath, the first thing to happen is your diaphragm drops. So your diaphragm is going to drop here. And that is going to create a negative pressure in your lungs. So the space is bigger, but the gas occupying it is smaller. And so you're going to have this negative pressure that ultimately is going to result in air coming in from the outside. So you have this negative pressure, like -2 centimeters of water in your lungs, and so that's going to pull things towards it, including blood. So it's going to pull this vena cava towards it and sort of stretch it open, which is going to allow more blood to fill into the right ventricle and the right atrium. So your CVP during inspiration in a spontaneously breathing patient, your pressure here is going to decrease because there is more space. Your lungs pulling your vena cava out, and things can rush into this negative pressure space, and so the pressure in your vena cava is going to be less, which is what your CVP is measuring. So it would be somewhere like here on your waveform. Then during expiration, your diaphragm comes back up, all the air is squished out, and you get positive pressure here. So that's going to push air out this way, and it's going to push the lungs out that way. So you're going to have an increased pressure on your vena cava during expiration, and so the pressure in your CVP is going to be a little bit higher, maybe here. So that is the reason that your CVP sort of oscillates, is because it is impacted by inspiration, because the lungs are in really close proximity to your vena cava. So now let's look at a mechanically vented patient. So the mechanically vented patient, the pressures are reversed. During inspiration, the vent forces air into the lungs with positive pressure. So forces it in like this, and that's going to force the lungs out in this direction during inspiration, which is going to put pressure on your vena cava. So your vena cava is going to see a high pressure during inspiration, and it's going to look like this. Then during expiration, your lungs are allowed to passively recoil, and they're going to push the air back out this way. So that relieves the pressure on your vena cava that the lungs were putting there. And so you have expiration has a lower pressure maybe here. So this was expiration for positive pressure. And this was inspiration for positive pressure. In contrast, inspiration with a spontaneously breathing patient had the low level. Spontaneous. Versus expiration, you had a higher pressure. So it's important to know where to read your CVP based on if the patient is vented or spontaneously breathing. And so the first way to understand that is to work through exactly what we did and figure out where is the pressure on the vena cava. But if you're looking for a mnemonic, to remember this quickly, I remember patient peak vent valley. So it's important to measure the CVP at end expiration, because at end expiration there should be little air left in your lungs, besides of course your functional residual capacity, but no extra air left in your lungs. So you want to measure at end expiration, and to just glance at your CVP and know if you should measure end expiration at the peak or at the valley. So this would be the valley, and this would be a peak. You look at patient peak vent valley. So if someone's vented, you measure at the valley. So right here, they're vented, and you're measuring it end expiration at the valley. Here, patient peak, someone's spontaneously breathing. So this is the patient breathing, and you're going to measure it at the peak. So really briefly, I'd like to tie all these concepts together so you can look at CVP and know how it affects preload, and then how that affects blood pressure. So you look at your CVP and really your CVP trend, and we'll say that it's low. So your CVP is low. You think consider volume problem. CVP is low, volume might be low. So if volume is low, there's not much volume here in your vena cava, meaning there's not much volume here in your ventricles, and so not much volume coming out of your heart. And so you have a low blood pressure. You might consider treating that with fluid, crystalloid, colloid, or blood products. So let's say on the other hand, you look at your CVP and it's high. So CVP is high. Again, consider a volume problem, but in this case, your volume is high. So you have too much volume here, meaning you're stretching your ventricles too much so they can't efficiently contract, and so you have less cardiac output and a lower blood pressure. So high CVP can also cause low blood pressure, in which case you might want to pull some fluid off, either with a fluid restriction, slow down your fluids, or consider giving a diuretic like Lasix. If you have a patient on positive pressure ventilation, especially with high PEEP, you might get a higher value because you have PEEP constantly pushing your lungs against your vena cava. And PEEP is positive end expiratory pressure, and it's continuous. And so you're going to constantly have pressure on your vena cava here, so you're constantly going to have less blood that can make it through here into your ventricle. And so then you have less preload, less cardiac output. So patients with very high PEEP might have a low cardiac output. So thank you for watching. Let me know what you thought, and stay tuned for a new video tying CVP and preload into stroke volume variation.